Welcome to the Culture of Healthcare, Healthcare Processes and Decision-Making. This is Lecture A. The component The Culture of Healthcare addresses job expectations in healthcare settings. It discusses how care is organized within a practice setting, privacy laws, and professional and ethical issues encountered in the workplace. The objectives for healthcare processes and decision-making are to describe the elements of the classic paradigm of the clinical process. List the types of information used by clinicians when they care for patients. Describe the steps required to manage information during the patient-clinician interaction. List the different information structures or formats used to organize clinical information. Explain what is meant by the hypothetico-deductive reasoning process. Explain the differences among observations, findings, syndromes, and diseases. Describe techniques or approaches used by clinicians to reach a diagnosis. List the major factors that clinicians consider when devising a management plan for a patient's condition, in addition to the diagnosis and recommended treatment. This lecture is concerned with healthcare processes and decision-making. In this paradigm, the basic assumption is that a single patient is interacting with a single clinician about a single problem during a single episode of care. Various tools may be used to mediate the interaction, including medical records, computers, and clinical decision support. However, this discussion focuses on the one patient, one problem, one clinician, one episode of care scenario, in part because it is realistic in many situations, and also because it helps to bound the problem. This classic paradigm is somewhat analogous to what has been called the central theorem of health informatics. The central theorem was articulated by Chuck Friedman, and his assumption in this theorem is that a human being working in the healthcare field will perform better when assisted by properly designed computer tools than when working alone. Most people working in biomedical informatics carry this assumption as the foundation of their work, even when it is unstated. Similarly, the classic paradigm is operative in many discussions, even when it is unstated. The paradigm is often assumed not only during the clinical process, such as making diagnostic or treatment decisions, but also during the interaction between clinicians and technology. For example, the interaction between the physician and the electronic health record. Because there is often a single patient with a single problem being addressed by a single clinician during a single visit, technologies have been developed that support this one-to-one-to-one-to-one arrangement. This lecture also discusses other healthcare configurations in which computer tools need to be designed to serve other purposes. But for now, the focus is on this classic concept of the patient-clinician relationship. This unit frequently uses the word clinician to refer to the individual who is providing care. It will be helpful to define this term more precisely. Here, the term clinician does not refer to a person who has any particular degree or educational background. After all, a person with a degree in nursing may be in a senior administrative position, such as the CEO. Most people would not call that work clinical. Similarly, a person with a doctorate in medicine may be developing computer systems or running a health insurance plan, and these forms of work are not clinical either. However, the work of patient care is performed by persons with a variety of educational and training backgrounds who may be considered clinicians. For the purposes of this lecture, the clinician is a person who possesses the following attributes. First, a clinician is someone who possesses specialized knowledge, which is usually obtained through extensive education, such as medical or nursing school. Second, a clinician is someone who has received extensive experiential training. For example, Fields such as nursing and medicine require post-classroom learning, substantial training, and practice under supervision so that the clinician learns how to apply formal knowledge in practice. Third, a clinician is a person who has a direct relationship with the patient. Regardless of one's training, indirect activities, such as setting policy about patient care, do not constitute clinical work, whereas direct interactions with the patient are considered clinical activities. Fourth, a clinician is someone who combines his or her knowledge, training, and experience to make decisions about patient care, such as assessment or management of the patient. Fifth, a clinician is a person who is expected to act in the best interest of the patient. This is referred to as a fiduciary responsibility, similar to that of a trustee for a trust or a board member for an organization. Clinicians are expected to make choices and perform actions that are not in their own best interest, but instead are best for the patient. Sixth, the clinician integrates diverse types of information, including not only individual knowledge of the patient and medical knowledge acquired in training, but also other information about local resources and constraints, as discussed later. Seventh, clinicians are almost always functioning within significant time and resource constraints. A clinician, then, is a person who possesses these attributes, whether it is a neurosurgeon, a clinical pharmacist, or a physical therapist. Clinicians use many different types of information when assessing and managing patients. The table lists 5 types of information that clinicians commonly use. The first type of information is patient data, or information that is specific to an individual person, such as whether he or she has allergies, a history of diabetes, or a heart murmur. This information is obtained from the patient, from family or friends, from medical records, or from the clinician's own observations while conducting the history and physical examination. The second type of information is population statistics, which refers to data that has been aggregated from individual patients. One version of population statistics is a clinician's informal knowledge of recent local history, such as recent flu outbreaks or a resurgence of whooping cough, which may be relevant to the findings in a particular case. A more formal version of population statistics might be a public health department publication about the frequency of diseases in a particular locale, or population-based reports that are obtained from a clinic or hospital's electronic health record. The third type of information is medical knowledge, the rules or conclusions about health and healthcare that are not just relevant to the individual patient, but are generalizable to many persons. This information may be obtained from textbooks, whether electronic or in print form, from reviews in journal articles, or from the medical literature. The fourth type of information, which is surprisingly useful for clinicians, is called logistic information. This focuses on how to get things done rather than on what to do. For example, the question is not whether a particular medication is indicated for a particular patient, but how to obtain that medication, or how to get it paid for. Not whether a particular type of surgery is indicated for a patient, but which surgeon is available to perform it, and how he or she may be reached. This type of information may be available from informal sources, such as the organizational knowledge of staff in the clinic or hospital, or formal sources, such as policy and procedure manuals, directories, or other institutional documents. The fifth type of information that physicians often use is called social influence, or the impact of others' job performance on the clinician's decisions. Clinicians may not always conform exactly to the practices of others, but in general, they like to know how other clinicians are managing particular problems, and whether their own practices align relatively well with those of others. In studying clinicians and their reasoning and decision-making processes, It is helpful to remember that all of these types of information may be brought to bear at various stages of the process. In addition to using many different types of information, clinicians organize and reorganize information in several ways as they manage a patient. Information typically begins in a narrative structure, becomes rearranged into a highly structured history and physical format, and then is rearranged again into meaningful groupings in a hierarchy, as described by Evans and Gadd. The manner of recording information, such as the SOAP, subjective, objective, assessment, and plan note, can be helpful in supporting the clinician's thinking, and other ad hoc structures are used as needed. Finally, this information may need to be reformulated into a computable structure so that healthcare information systems can use the information for decision support, quality improvement, and research. Although a great deal of effort is devoted to giving structure to clinical data, the narrative structure is pervasive throughout the clinical process. This slide contains an old saying in healthcare attributed to Philip A. Tumulty that says, quote, "Disease hides its secrets in a casual parenthesis," unquote. This means that despite the clinician's attempt to elicit useful information about the patient's problem by asking pointed and directed questions, critical clues may emerge only when the patient is simply allowed to tell his or her story. In fact, the clinical process almost always begins and very often ends with a narrative. Catherine Montgomery Hunter has examined some of the many ways that stories are used and why they are important to the healthcare system. First, stories are the principal communication between patient and clinician. Before asking direct and pointed questions, clinicians are taught to ask open-ended questions that allow the patient to tell his or her story in its native form. This enables the clinician not only to find facts embedded in the stories that are meaningful for generating a diagnosis, but also to understand the meaning of the illness for the patient. Listening to the story is an important part of relationship building and may have therapeutic value on its own. This can be a very important aspect of the quality of care as perceived by the patient. Stories or structured narratives are also a form of efficient communication among clinicians when discussing the patient. Storytelling in healthcare settings is also an important part of the hidden curriculum through which values and ethics are communicated, often informally. Unfortunately, our modern and often fragmented healthcare system does not always deal well with stories because of the constraints of time, the multidisciplinary process, and other factors. As a result, clinicians may eliminate or alter stories, reduce opportunities to hear them, or extract information from them incorrectly, losing important context or details. As clinicians gather information and decide what to do for each patient, their interpretation of the data depends on many factors. First, there are professional and disciplinary differences. A neurologist and a psychiatrist examining the same patient may elicit and focus on very different information and make different sense of it. Clinicians may also use differing approaches to interpreting clinical data as they attempt to reach a diagnosis. When observing clinicians working in groups, it becomes apparent that an important part of interpretation, especially in interdisciplinary care, is social construction, or the meaning that arises as clinicians discuss a patient. This can be observed in settings such as the intensive care unit. During ICU rounds, the conversation among the participants often allows insight and consensus to emerge. Perhaps most important, clinicians' interpretation of data depends on context, the patient's context, the clinician's context, the setting, and other factors. A single piece of information may have very different implications depending on these contexts. This slide depicts the classic paradigm with one patient, one problem, one clinician, and one visit, and compares it to an alternate situation, the operating room. Surgical procedures usually involve one visit and are concerned with one problem in a single patient. During surgical procedures, however, many clinicians from many disciplines may participate in the process and share information and collaborate in a synchronous fashion. The setting is also characterized by a relatively short time horizon and a fairly narrow clinical focus, as well as substantial advanced planning and rich resource availability. These differences may have implications for the kinds of health information technologies that will be helpful to the clinicians involved. Another setting that differs from the classic paradigm is complex acute illness. In this setting, one patient may be cared for in one or more visits by multiple clinicians dealing with multiple health problems. For example, the patient may have lung disease, kidney disease, joint disease, an infection, or pre-existing chronic conditions such as diabetes and hypertension. In this scenario, multiple clinicians may perform multiple tasks over one or several patient visits. There is often a short time horizon, as well as unplanned events. Additionally, there is almost always a great deal of uncertainty about some of the data, especially in critical care settings that tend to be focused on immediate goals. Because of unanticipated events and uncertain data, clinicians must remain flexible to allow dynamic replanning as necessary. Healthcare information systems designed for such a context might have different requirements than those designed for simple one-to-one settings. Yet another example in which healthcare goes beyond the classic paradigm is the emergency department. Here, there are many patients with many different clinical problems being treated simultaneously by many different clinicians, usually involving a single visit, although in some cases there may have been previous episodes of care. Both acute and non-acute conditions must be treated. The very short time horizon in emergency departments is captured in the expression, treat 'em and street 'em, because of the need to constantly keep things moving. Clinicians must be prepared for the unexpected, even in the face of significant resource constraints. Also mandatory are effective coordination, cooperation, and collaboration among the many individuals participating in the care. Once again, these factors may have a significant influence on the kinds of information technology that will be helpful in this setting. Having considered several alternative healthcare scenarios, this slide returns to the classic paradigm. People who consult with a clinician are, in general, looking for the answers to three questions. What is the matter? What can be done about it? What will happen to me? These questions correspond to the classic steps that clinicians take to make a diagnosis, recommend treatment, and make a prognosis. The remainder of this unit examines how clinicians gather data from the patient, analyze findings within that data, make sense from it to reach a diagnosis, consider that diagnosis along with many other contextual factors to recommend a treatment or management plan, and finally, communicate their results to a variety of interested parties. This concludes Lecture A of Healthcare Processes and Decision-Making. In summary, this lecture looked at the central theorem of health informatics and at the types of information that clinicians use while managing patients. The role and nature of a clinician were defined. The classic paradigm of the clinical process was outlined, and some alternate paradigms were discussed. The typical questions that patients ask were correlated with the classic steps that clinicians use to make a diagnosis and devise a treatment plan.